So welcome everybody. Thank you so much for joining us for this discussion panel. This is part of WAAC's campaign, STIs Happen, Be Proud to Test. And we're really passionate about spreading this message and excited to have some wonderful people to join us for this panel discussion to help bust the stigma and just have some really important conversations around this topic. Before we get started and move any further, I'm just going to do an acknowledgement of country. So I just want to acknowledge the Whadjuk people of the Noongar Nation and pay my respects to elders past, present and emerging. One of the things that I truly respect about our Aboriginal people is their connection to country, and it's something that I try and read about and try and learn about and try and embody to pay my respects to the way that they have that relationship with country. So if I could just invite everybody to take a moment and think about something for them that's personal, that helps them to feel connected to the country that they are from, just to try and embody that beautiful way that we are taught to connect to our country. And it's something that I think can be really personal for us. So just taking that time, and then we're going to get started. So thank you all for being here today. I'm going to start by introducing all of our panel members. So I'm going to start by introducing the wonderful people that have joined us here today to speak to this discussion. So maybe you guys could give us a wave as I introduce you. I've got Elena Donaghy here. She's a sexual health nurse from Derbarl, Yerrigan. Hi, Elena. I've got Matt Jones here. He's our clinical nurse consultant from the clinic. Hi, Matt. Thank you for being here. We've got Drew Sweet, who's a peer educator at that's a youth education project. And we've got Karen Molhuyen. She's in health promotion at SHQ. Got it right, yes. And we've got Cara, Taheny, and she's a sexual health nurse from West End Medical. Hi, Cara, thank you so much for being here. And what we're going to do is jump straight into the questions that I've got here. We've all sort of planned out these questions because we think they're really important. But to anybody that's watching, if you've got any questions, as I mentioned, you're all on mute just so that we've got enough time for everybody to share that's part of the panel. If you have questions, please just pop them in the chat. And I've got my colleagues here, Sharmila and Beck, and they're going to be here to kind of help wade through the questions if we have any, and we'll try and get to them at the end or throughout the discussion when we can. So let's jump into it. Let's get started. So my first question is just to get each of the speakers to tell us a little bit about them, like their services basically, and what populations of people their service basically exists to support. Elena, if we could start with you.
Yep. So I'm from Derbarl Yerrigan Health Service. We service, obviously, we're a service for Aboriginal people. We have 4 sites in Perth. So there's Midland, Mirrabooka, Maddington, and then the East Perth Clinic. But so that East Perth feels connected to the other clinics, I've decided it's also the Metro Clinic. So they all start with M. With our services, we provide primary health care. So there's lots of doctors running clinics from newborns right through to people who are 99 and older. We have a dental service, we have a maternal child health team, we have a counselling service, we have social workers on board, there's a podiatrist, we have visiting specialists. We also have NDIS community connector. With our service, we can sometimes offer things like home visits. We do a lot of liaising with other organisations, a lot of advocacy for our clients. We can provide emergency relief, and we do a lot of health promotion. We do run a needle and syringe program. We have an appointment reminder system, and we can even do things like offer transport to some people. Wow. Most of our clients are in that metro area, but we do have transient people coming from the lands as well.
Amazing. Thank you so much for that rundown, Elena. I actually didn't even know that you've had that many services available. Amazing. Thank you so much. Drew, we'll come to you next.
sorry, I had to remember how to unmute myself. Hi, yes, so I'm Drew Sweet. I am with the Youth Educating Peers Project. We are a sex positive and harm minimization youth-focused sexual education program. So we mainly cater to young people aged 12 to 25 and provide them with the knowledge and skills about their own sexual health. We don't provide any testing services or anything that ourselves. Instead, we work with organizations like those that are present today to push the young people to where they need to be, so they know where to access these services and so for their own sexual health. What we do offer is resources and workshops for young people and members of the youth sector that focus on topics like sexual health, healthy relationships, STI and bloodborne virus testing. We have paused our face-to-face workshops for the moment just because of everything that's going on with COVID and everything, but we are still running our online workshops. And we've also recently started up a consultation service, which is a support service to make other services more youth-friendly. So if a service wants to cater more specifically to young people aged 12 to 25, we can work with them, see what their needs are, what the expectations of the young people are, and help them develop them in that professional capacity as well.
Amazing. Thank you so much for that, Drew. That's awesome. And then Karen, will come to you.
Thank you, Erika. Yes, SHQ, we are sexual health quarters. We provide sexual and reproductive health services for everybody. Our services include a clinic, doctors and nurses in Northbridge, and they provide a full range of sexual health services, including STI testing and treatment. We have a counselling team who offer counselling around sexuality, sexual health issues. We have the PIP team, People First, which is our service for people with disability, and that offers education, advocacy, counselling and professional development in sexuality issues for people with disability. Magenta is our service for supporting sex workers. So we have a clinic off-site from our Rose Street clinic, and that is our Magenta clinic, which our doctors and nurses offer clinical services to sex workers. Magenta also offers advocacy, outreach, support and professional development for sex workers. And we have our education team, of which I'm the coordinator, but we have a team of 5 other educators other than me, and they are all young people, either peer educators or youth educators. And we offer workshops for young people around any topic to do with sexuality, sexual health, consent, respectful relationships, etc. And we offer professional development training for people working with young people. We're based in Metro, but we do travel regionally as well. And we also offer a youth clinic, which is available for young people on Tuesday nights.
Amazing.
Our priority populations, while we are open, we are here for everybody. Our priority populations are people who are marginalised, disadvantaged, or from disadvantaged backgrounds, also Aboriginal people, LGBTIQA plus community, people from migrant and refugee backgrounds, and people from culturally and linguistically diverse communities.
Thank you so much already, guys, because it feels so good to hear everything laid out, and you've got so many services that you offer. It's quite amazing. Thank you so much. And Matt, will come to you.
Yeah, hi everyone. So I'm Matt. I'm one of the clinical nurse consultants over at the M Clinic, which is one of the big projects by WAAC. We've been around for, I think we're pushing 12 years now. So our priority population is men who have sex with men. And we have branched out a little bit just to include other people who have severe if not more, barriers to testing and healthcare than just the gay population. So we do see trans. The services we offer is mainly sexual health testing, treatment and education. We do work with the community in terms of assisting people to get the sexual health care that they need. We do work with GPs. We do accept referrals from other clinicians in terms of any extra service they might need in terms of education, counselling, support, mental health brief intervention, and stuff like that. And we do quite a few referrals in terms of social needs as well. We are primarily nurse-led and peer-led as well. So everyone who works at M Clinic, or mostly everyone, is part of the LGBTI community. And if they're not directly part of the LGBTI community, they're definitely allies, which is fantastic. Yeah, that's it.
Perfect. Thank you so much, Matt. That's awesome. And last but certainly not least, Cara.
Hey, so I'm Cara. I work at West End Medical, which is a private general practice in Fremantle. So not only does it do general practice, it is a sexual health clinic, so it receives a lot of referrals from external providers or GPs, often to do with sexual dysfunction, hormonal issues, so estrogen implants and that sort of stuff, relationship counselling. There's only 2 clinic rooms here, so it's quite small and boutique, and then there's a treatment room which I sit in. So there's a combination of GPs. There's a nurse practitioner that works here at the moment as well. I'm the practice nurse, and then with our services, usually there's a gap fee, so there usually will be that, but we do bulk bill Notre Dame staff and students, people on concession, pension cards, full-time students and kids. Clientele-wise, it's a real mixed bag. So obviously there's a lot of uni students, backpackers, a lot of older local 3O people. Stephen Adams is the owner of the practice, and he's got a following from people that have seen him over the last 20 years in clinics in Perth. A lot of uni students, kids, babies. We do a lot of vaccinations and just general GP stuff. And then obviously there's a significant, I'd say, trans population. I think there's probably over 70 patients Stephen sees here. So yeah, it's definitely a mixed bag. It's good. That's us.
Great, thank you so much, guys, and such a mixed array of different experiences as well. So it's really excited to jump into these questions now to get all of your insights from the different populations that you work with. So thank you so much for that, guys. The next question I've got for you, I'm going to dive straight into it. In terms of your experience, what are the most common fears or apprehensions that people have towards getting tested for STIs? Elena, we'll start with you.
Okay. One of the first things that comes up for us is a lot of our Aboriginal staff know the patients. So a big one's going to be confidentiality. So that's a huge thing. People absolutely don't want to be judged. They're worried about their confidentiality. Sometimes they have like needle phobias, or they're scared that we're going to be putting great big long swabs down places that they don't want them to go. So just maybe myths that they've heard out in the community of what might happen will be a barrier. And then what happens if there's a positive result? So there can be stigma, shame, and just that idea of what it means to have a positive result, whether it's real or if it's some sort of a myth that they've heard.
Yeah, absolutely. I think it's all the things you brought up there are so important, and even down to if you do go in for the test, it's the fear of what's going to happen afterwards. It's that unknown, even the what ifs around and the cultural sort of fears or pressures that are put on for having an STI, even if you did test positive. So yeah, definitely. Thank you so much, Elena. And Drew, in the young population, what do you find?
Yeah, so the young population is a bit, they've obviously got their own specific concerns, generally around shame, stigma, and guilt, as with everything to do with sex, sexual health, and stuff. There's a lot of those emotions that are sort of that people internalize, the young people internalize. They often haven't had experiences going by themselves to clinics to begin with, let alone for a sexual health checkup, and don't understand what that means. So that's a large part of what our resources try to do, is try to just normalize that, hey, exactly like this campaign is all about. STIs happen. It's a normal thing to go get tested. It's a normal thing to look after your health like you would any other part. A misunderstanding of what a diagnosis means is another big one as well. The idea that, oh, now I've got this permanently, like this means it's going to affect me permanently, when really it's just a course of antibiotics or whatever have you. They're still trying to figure everything out. So it's really just a normalization, taking away all that mystery, taking away that fear of like shame, judgment, all that kind of stuff.
Yeah, definitely. I think there's so much to this. And I think when you're working in it all the time, you don't necessarily, it's like, oh, you understand. But for someone that's being introduced to it, there is a lot of information, which is why we so appreciate that you're all here having this conversation, because it takes just keep talking, keep introducing another bit of information, keep dispel a myth, teach them about this, or educate or have a discussion about that. So yeah, absolutely. I think that's one of the biggest ones I found as well. So really important stuff. Thank you, Drew. Karen, what have you found in your experience?
Yes, certainly echo what Drew and Elena said, that the young people that we work with, or people that we work with, I think it comes down to fear of the unknown. I think talking about STIs and talking about STI testing is often clouded in secrecy. People don't drop it into daily conversation. I would love to hear people say, oh yeah, I'm going into town on Tuesday, I'm going to have a coffee, and then I'm going for my STI test.
Yes.
It's just not part of our conversation. And so particularly young people, it doesn't get spoken about, so they don't know. And if they don't know, there's often fear of what's going to happen, who's going to get told, what happens when I go in there. Echoing what Elena and Drew said, I think confidentiality is huge. I think oftentimes for those of us that work in the sector, one of the most important things we can do is let young people know what their rights are, and that includes their right to confidentiality, their right to be treated with respect, their right to friendly and non-judgmental service. So them not being aware of what their rights are, I think can lead to their fear about what's going to happen, fear of the unknown.
I'm really interested as well in one of your priority populations was culturally and linguistically diverse people. And even in that cohort, there's a whole, I know I actually just did a training myself. It's not that I've got that much experience, but talking about the cultural kind of pressures or expectations. So when we're talking from Elena's point of view about what can happen afterwards,
and I think those issues are even more complex for young people in those communities. For example, sadly, the number of times I've had a young person from a migrant or refugee background express to me that they're frightened to come into any clinic for help around sexual health, because what if they tell immigration? What if it impacts my visa? What if they tell my family? So for young ones from CALD community, they may have even less knowledge around what their rights are in accessing best practice sexual health services, which all of us here today know are there for them. And we know that once they're in the door, whether it's at Derbarl or M Clinic or SHQ or any of the others, West End, they'll have beautiful, respectful consultation. But sometimes for young ones, for those communities, just getting in the door is the biggest barrier for them.
Absolutely. Just asking the question. There's so much fear around reaching out and asking the question, which is, it's really sad. So thank you for speaking to that, Karen. Matt, let's move on to you. Same question to you, please.
Yeah, so yeah, I mean, I have to echo what everyone else has said. Yeah, we see a lot of like the term I sort of stick with is MSM, which it does include your heterosexual identifying man who dabbles or for whatever reason is wanting to have sex with other men. And it's multiple reasons. I'm sure we've all come across it, that it's like it might be just easy access to sexual activity. It could be a gratification thing. It could be an experimental thing. Or it could be for whatever societal, cultural or religious reasons that they're in a normative heterosexual relationship when they know that they're not actually heterosexual themselves. And obviously that brings up the issue of confidentiality. Some people think that our GP software is linked to everyone else's GP software and to the hospitals and stuff like that. So it is again all that education. It is the judgment. Like even people, I remember, I mean, not so much with this clinic that we've moved because we've already got a front entrance, but pardon the pun, at our old clinic we had a rear entrance. That people would actually call and say, look, I'm actually at the back door. Can you let me in? Just because I didn't want to be seen sort of going up sort of the front stairs, if anyone's familiar with our older building, in fear of someone walking by and seeing them come in. And to the point where people even use pseudonyms and different dates of birth, and which is fine if they can actually remember it, because it makes giving results a little bit difficult. The other thing I do find on occasion is people who are new to Australia and they don't necessarily, like they've never had sexual health education. They don't really understand what safer sex is and what some of the conditions can arise from not using condoms or having sex with strangers or stuff like that, that puts people at higher risk of contracting some of the more serious STIs. I mean, I do remember one guy saying that he was, and it was a refugee guy. He was tortured on the assumption of being gay when he came to Australia and found how relatively progressive we were. That he just went and had sex with everyone because he knows there weren't going to be any social or legal repercussions for it. So that sort of vulnerable population is very important for the education. The other thing I do find is in terms of contact tracing, which is when a person has an infection, they do this to sell their sexual partners, and often with the heterosexual men who have sex with men. That can obviously be very challenging, as most of the other clinicians here can attest to. But yeah, a lot of the apprehension to sort of come into tests, I think some of the other speakers mentioned, is actually getting them through the door, and especially with young people as well. So a part of my role at the moment is on the phones, and when people sort of come in, whether they're young or having these barriers to actually get in the door, involves significant conversation in terms of what Cara and Elena have alluded to in terms of what their rights are, their right to confidentiality, and to reassure them that just to try and normalise STI testing, and that the results aren't going to go anywhere that's going to jeopardise their situations. Yeah.
Wow. Thank you so much for that, Matt. And as we can already see, it's just such a complex, it's a huge topic, such complex answers coming from that one question already. It's just incredible to hear about all the things that people go through in this sector. So last but not least, again, Cara, what's your experience?
I guess the things to add on would be understanding of my health record and MyGov and Medicare and what parents might be able to access. I still find that confusing myself as a clinician, and a hard one to navigate. Cost associated with appointments and testing, particularly for people that can't afford it. The other thing would be accessibility. So having a timely service. So there's nothing worse when someone has to wait 4 days to get seen at some of the clinics around Perth, and that makes it really frustrating. So that would be another one. Also, just that fear of recognition. Definitely what Matt said about if regular partners aren't aware of someone having other sexual partners and there's a positive result, what that means for telling someone not only about an STI, but the fact that they're having sex outside that relationship, that can stop people. Also, just having a competent clinician. So is the person I'm going to see know what they're doing, know what they're testing for, know that it might be different, those sort of things, and not just having a rubber stamp every STI test looks like. That's probably the main thing. And just people's fear of thinking other people know why they're presenting. So obviously Derbarl, West End Medical, we're a bit different in the sense that we offer a multitude of services. So you're not feeling like you're sitting there with a hat on that says I'm having a chlamydia test. But obviously more specialised services, that can be that fear when they're waiting in the waiting room, because it is a more niche market. That's probably it.
Absolutely. Oh, thank you so much, guys, for your comprehensive answers to that question. The hope with that was that somebody watching this will be like, oh, I feel validated. That's me. That's maybe that's how I felt before. So yeah, great answers there. I'm going to kind of open up the floor a little bit now and just see. So to whoever wants to sort of unmute and answer next, I'd love to know what kind of advice or tools that you would like give or use with someone who is nervous about getting tested. What would you say, or what would you do? Anybody want to jump in?
I can.
Yeah.
So things that we have, so we are online, like we have a website and we have bios for every clinician. So just having those bios and that photo gives some familiarity about who you might see and what they're about. And I think that can be quite helpful. Obviously, introductions are always good. So making sure you say who you are and what your role is, that sort of basic stuff. I think sometimes we make an assumption of who we're seeing. And obviously just that friendly, approachable stuff. Like, you know, I'll take phone calls from people that might have some questions about how do you get a test at your service, that sort of stuff. So being available is often part of that. Obviously, and there's heaps of online YouTube stuff. People at SHQ's the same, where they've done heaps of stuff into expectations of an STI test and what to expect. So I find that online stuff really valuable to show what to expect. Also, sometimes if I've seen, this is at other workplaces where I may not be able to see someone timely, I'll talk to them and get a brief history on the phone, and then I might email them or get them to write down what tests they should be asking for if they go see some random GP somewhere, just so that they have got an idea of what they should be testing for. And obviously, again, just having that competence in what you're talking about, you need to own it and know what you're talking about. And if you're not sure, say it. Fudging your way.
That builds trust in itself, doesn't it? Builds trust.
Yeah.
Pretty sure
exactly.
I'll find out for you. Yeah.
Yeah. Not being scared to say, shit, I don't know that one, I will find out. So yeah, that would be my hot tip.
Amazing. Thanks so much, Cara. Anybody else? Top tips?
Yeah, I think the other thing, just adding on to what Cara was saying, is with COVID, and I know this is one of the other topics that we're discussing, but with COVID, when we're sort of forced to move to, well, with us anyway, a lot of telehealth consult, it does sort of lay down that sort of that rapport, especially if people, like, they'll book and they may not come in, as opposed to like they book, they have a telehealth consult, or even when they call, if someone's got time, we can actually do a consult over the phone, and that might be enough to yes, we can email them a form, they can get their tests done, or they can come in once they've had that phone consult and have their samples collected here at the clinic. I think even that not necessarily being face-to-face, but having that rapport without the, oh my God, who am I going to see? What judgment is there? So you can actually develop that rapport without a face-to-face, and then say, okay, no worries, look, you're going to come in and get your samples today, and Gary, who's a fantastic nurse, is going to see you, and you can actually handball that to one of the clinicians. So by the time they actually come in, if they are going to come in for their samples, they already have a really good idea of that it's going to be a safe, comfortable environment as well.
And I love that we've kind of come on. What you're talking about, Matt, is that building that rapport and making it personal, like using people's names, making it personal, and giving them an idea of what to expect, because it's the fear of the unknown that Elena was first talking about that is one of the barriers. And then jumping to what Cara said about Cara and SHQ and the resources that you have online, just to give people that idea as well. So yeah, really important stuff. Anything else to add as well, Cara?
Yes, similar themes of just empowering people, giving them access to knowledge, building their skills, building their confidence, and giving them access to knowledge in whichever way works well for them. For some people, it might be that they get to participate in a workshop with the YEP crew, or participate in a workshop with our youth team, maybe encouraging them to go online and do their own research and look at what services are there. And as Cara was saying, check out who the staff are, check out what the process is before they come in. Or it might be more informal but super valuable access to knowledge, where I know a lot of us in the sector spend time working on what we call the peer education model. So we might upskill a group of young people in called community, or upskill a group of young people in Banksy Hill detention or in a school environment, and build up their confidence and their knowledge, really valuing that they will then have conversations with other young people, and that they will normalise those conversations, and that they will be able to be a source of information and encourage others in their groups. So finding ways to increase people's knowledge in whatever way that is that works for them. I think that's our role to help reduce the barriers and reduce the fear.
Amazing, thank you so much. Any other brains that want to add to that question?
Yeah, so I think echoing what everyone else has been saying, transparency and education and knowledge are the two main goals, main factors that I think all of our organisations are pushing towards, right? One thing that YEP does is we have a referral resource that we hand out to the young people at all of our workshops, and it's available online. And it's basically just a couple of sheets that list out all the places that you can get sexual, like STI testing, sexual health services within the Perth region, and we have all these accessibility icons that say, hey, this specific clinic focuses on LGBTQIA+ health, or focuses on Aboriginal and Torres Strait Islanders, and is accessible via wheelchair, and tries to just put that information out there so that the young people know. It can be like, oh, okay, cool, I have these requirements. What are the sexual health services that I can access that are going to be comfortable for me? Because it just takes that guesswork out of, and it takes that guesswork out of going to get an STI test, and especially for a young person who hasn't done that a lot, removing as many barriers and shining a light through that fog, that mysterious fog that is making it hard for them to get tested, is really important. We also have, I think Matt was talking about COVID times, socially distanced STI testing is the thing now as well. So we have resources to help young people, do testing from their own homes. So that way they don't have to, during the peak of COVID, we did a lot of work surrounding this, go out to hotspots and expose themselves if they're immunocompromised or need to isolate or anything like that. And yeah.
Amazing. Thank you so much, guys. This is just, I know when we're talking about difficult things, I'm like smiling, I'm beaming, because there's so much information on this. We're lucky we're recording it as well, so hopefully we can continue to use this information. So now we've been talking a lot about education, throwing a light on things, and obviously having to wade through a lot of the information. So I'd love to get a little bit more specific with the next question, just to give an idea of some of the services that are out there and what to expect. So specifically for the sexual health services in this space now, what does a booking or inquiry system, and Drew, feel free to answer that as well in terms of anybody that wants to get in touch with your services, and what does an STI screen currently look like at your service? Again, popcorn it. Whoever wants to go first.
I'll get out of the way because we don't actually offer sexual health like testing services yet. So what we do is direct people using things like the referral resource to places like SHQ and everything. We aren't taking bookings for workshops and stuff at the moment just because of COVID stuff, but that's going to be reassessed at the beginning of April. And so you can go onto our website and follow us on social media and stuff like that. We're on Instagram, TikTok, and Facebook. We are always reposting everything that M Clinic, SHQ is all doing, all these organizations are doing, so that we're getting that information out there. That's what we do for our part.
Great, thank you so much, Drew. Elena, I haven't heard from you for a little while. I'd love to hear about your service and what an STI screen looks like at Derbarl.
So if somebody comes, we screen them for why they're presenting, and sometimes it's really obvious that they do initiate their own STI screen. If not, the clinician will bring up the subject and have the discussion with them. We also, say if somebody's coming to me for a cervical screening test, it's one of the opportunistic things that we would offer. And then if people are needing to do things like going off to the toilet to provide a urine sample, I'm really mindful to make sure that they've got a paper bag or somewhere that they can walk through the clinic, because the toilet's not always next door to the clinic room, making sure that they can be really discreet about their samples and those sort of things. And
I like that, Elena. That plastic bag is not always the best walking through the corridor.
But also negotiating what tests are going to be done. So for the needle phobic person, we might be able to negotiate, well, is this a good time to do it or not? And is there an alternative that we can an alternative test that we can do? Just having those negotiations with people.
Amazing. I think that negotiation is a really important, and it's a nice strong word as well, I think, for this, because I think a lot of people think they're going to be going into a space where, the doctor, they're the professional and what they say is going to go. And again, it's coming down to that ethical or moral standpoint we're talking about, is knowing their rights, and that they've got, helping people to feel like they've got a discussive element in this, that they can actually talk to you about it. It's not a case of, well, now you're here, we're just going to focus on all these places. So that's awesome. Thanks, Elena. Anybody else want to jump in?
I will. Currently at FHQ, if somebody is ringing for an STI screen, if they are asymptomatic, then they will first have a telehealth consult. And then after that, there's a choice. They can either come in to have any swabs done, for example, or they can do that themselves at home. If they, in consultation with their clinician, decide that a blood test is required, they would need to come either here for that blood test, or they could present at a pathology that's nearby to them to make it easier. If somebody is symptomatic and they ring SHQ and they're symptomatic, they will be put through to our nurse, who will have the conversation and triage from there. So similarly to other services, it's a triage process. I would like to say, though, that I think telehealth, it might have been COVID that pushed us into that space. And I know there are many people that may have discomfort around it, but I have heard so many people say that they love telehealth. And I think that telehealth has fantastic. It can be a way of, as Matt said, building that rapport. I think for some people that might feel hesitant to come in, starting with a telehealth consult that they could be sitting in their car on the phone, they could, you know, in a private space, and have that conversation first with a clinician. Is fantastic. So telehealth has got a lot going for it.
Yeah, I hear you there, Cara. And that speaks to what Matt was talking about in terms of that rapport building as well, and just having a space to be able to be in contact with your clinician before you actually go in. Again, it's addresses one of those barriers to getting people through the door. And if you do,
yes, and echoing what you said. Oh, sorry, Erika, apologies. I spoke over the top of you. Echoing what you said around it being a discussion, I think, again, those of us that are educators, it goes back to us as our role really is to support and empower people to get in the door to sit with their clinician, because we know the beautiful service they're going to have once they're with their clinician. And so sometimes I think the biggest role for us is to say to young people, if you're going for an STI test, it's a conversation first. That's the biggest part of it. You don't have to go in there and get your gear off and have the nurse, you know, getting all up in your bits. It's a conversation. Like, go in and sit down and chat with the nurse. The nurse will talk with you and step you through and tell you what they recommend and what would you like to do. So reassuring them that it is, as you say, a discussion, and supporting them in the door, because we know that once they're sitting there with their clinician, with this in those skilled hands, they will be supported through to the next step of the process.
Yeah, I think specifically for those vulnerable populations too, is that notion of body autonomy and consent. Like there's that your clinician's going to say what they think, you know, after appraising and after having a discussion, what they think would be best for you. You still get to consent to that.
Yeah.
Or that thing. So yeah, definitely. I love that, Karen. That's awesome. I think we could talk about this for ages, but Matt and Cara, I'd love to hear from you guys too.
Yeah, so our triage is similar to what Karen is speaking of, that every person pretty much gets triaged. If they're asymptomatic and happy to do their sample collections through one of the labs, then it's very easy to send them a pathology form and they can do that. If they're symptomatic, it is sort of a two-step process, because we try to work it around in terms of the government's definition of a close contact, which we sort of ascertain as a 15-minute limit. So we can do like whether they're at home and then they come in, or whether they park at the front and whoever's seeing them phones them. So then they come in, get their samples done. If they need an injectable treatment, obviously they do come in. And with contacts as well, a lot of discussions that I'm having is like, from a public health point of view, that the wording in there says, okay, if they're MSM, you need to treat everybody, because God forbid we're going to go and have sex with a million people. But a lot of the conversations I have is like, okay, you're a contact of chlamydia, you're not symptomatic, are you happy to test and wait 4 days for results, and you're happy to not have sex during that time? So a lot of it is exactly like Karen said, is collaborating with the client or the patient, excuse me, and coming to an agreement with them as which is going to contribute to rapport as opposed to sort of prescripting a consult, I guess. But yeah, we sort of try to work out, okay, if they need to come in, if they need an injectable, or if we can get away, and even with the contacts, if they do test positive for chlamydia and they have the ability to pay for a script and actually have Medicare and all that sort of stuff, then we usually get one of our doctors who aren't here every day, but if it sort of lines up with when they're in, we can quite easily just send a script to a local pharmacy so they can get tested and treated without actually physically coming in at all.
Yeah, amazing. See, all of those little things that you're talking about, when you were talking then, I was thinking it's humanizing the client and the patient, and kind of it's not or I know here's the directive from the government, here's what we need to do in response to this symptomatic STI, whatever it might be, but at the same time, we're actually going to humanize it and go, hey,
exactly.
do this, and yeah, so again, responding to the person in front of you rather than just going, oh, you've become a statistic now, which I think a lot of people, that's another one of the fears, is just I'm going to go in and just get put through the mill I'm treated like I'm human and I'm an individual and have specific needs and that sort of thing. So amazing. And Cara, do you have anything to add on there as well?
Yeah, I guess for us, apart from general COVID stuff, we're business as usual. So everyone still comes in and sees us. We're doing all our vaccinating kids, whatever. So they just have the usual screening on arrival about symptoms and stuff like that, or close contact. My background's sexual reproductive health, so thankfully the doctor's really supportive of my practice, and so we have bookings with myself. So anyone that needs cervical screening or STI screening or has genital symptoms they're concerned about, they can book in with me either online or via the phone, and usually it's same day. To be honest, sometimes you can get in within half an hour. So that's been really good. Obviously telehealth is an option with the GPs and nurse practitioner for lots of different reasons. Apart from that, with our pathology, it's all on site, so there's no issue with there. No one has to go anywhere else, so we can do it all at the same time. Apart from that, with appointments, so booking in for me, for instance, you can tick that it's for an STI screen or a cervical screen or whatever. But sometimes people will phone, and so there often will be a few questions asked just to make sure you're getting in with the right person, because obviously we do trans health and erectile dysfunction and stuff like that, so we want to make sure that you're not seeing me for some of that stuff, because I'll have no idea half the time. The good thing is I'm in the last, I get to do advanced practice stuff, and so if I think there's radiology or pathology or treatment that needs to happen, I'll discuss with the doctor and they'll come in and we'll sort that out then and there. And so that sort of reactionary, opportunistic stuff's been really good, and it keeps me sane as well, doing the sexual health stuff. So yeah, there's no difference to how we're working.
Amazing. So I think one of the messages that I think I've taken away from that, to somebody, for example, that might be watching this, have never had a test before or feeling apprehensive about a test, is that we are going to be talking about some things that might be uncomfortable. You are going to get questions, but at the end of the day, choosing a service or a practitioner that's going to be discussive with you and treat you like a human being, and actually going to be engaging in that conversation with you, and that you have rights, and you can say, oh, I'm feeling a bit uncomfortable about that, or I'd rather just discuss that with the doctor when I get in to see them, or I'd rather not do that today, but thank you for the information, and those sorts of things. You've got a right to say that. So everyone, I'm mindful, we've got 10 minutes left of our panel today. So anybody that's watching that maybe has questions or comments, please feel free to type them in now. We can see if we can address them before the end. I'd love to just throw in, I'm getting a bit passionate hearing you all talking, and I'd love to throw in sort of for some parting comments from you guys. Because of our campaign is STIs, they happen, and be proud to test. I'm not going to go as far as say, why should somebody, because I don't think we should ever tell people how they should feel. But can you all share perhaps a message that would speak to, helping people to feel prouder about testing for STIs and taking care of their sexual health? Take a moment to think. I know I've just thrown it in there.
Yeah, I mean, a lot of the discussions I have with people is around normalising STI testing. And it is still a thing with people who are testing regularly as well, and if they come across and they have a chlamydia diagnosis, for example, and they get really down about it, and I said, well, look, I mean, it's a side effect of you expressing yourself sexually, which is human nature. It's not like no one's doing anything wrong or bad. Like, there's always this connotation, I feel, of when people come in and they have to get treated for something, that they've done something wrong, and it's it's just normalizing that look, this stuff is out there. Yes, there are steps you can take, whether it's PrEP, condoms, more regular testing, to reduce your risk. But I always put in there, I mean, most of our guys, I think, are testing six monthly or 3 monthly, and we do have quite a heavy PrEP client load as well. So they're obviously attending every 3 months. And it's like, I mean, even around HIV, which is the one thing that we can't completely fix yet. And we all know from a medical point of view, it's all reasonably well managed. That the thought around that, yes, there's still a lot of stigma, which is, I think, by far much more of a concern than the medical side of things, is just the normalizing of the testing and saying, look, no matter what we find, including hepatitis, HIV, with the regular testing and normalizing regular testing, that we are going to find these things early, and the prognosis of anything is going to be very, very good. So that's a lot of, that's conversations that I have every day. Yeah.
Amazing. And I love what you said there, Matt, about normalizing the results, like what Elena was talking about, the fear of what's going to happen if there is a positive result, normalizing that process, but also normalizing the actions that get us there, humanizing the actions that get us there. If you're having sex and you're enjoying yourself, it's just, chlamydia is a likely or a possible side effect of that, but it's not a sign that something wrong has happened or something you've done something bad, or a punishment for your sexual choices or something like that, which I think that's an amazing message. Thanks,
I think it is important to note, hearing you speak about that, in terms of the reasons why people get there, I think is what you said. And sometimes you need to scratch that surface a little bit in terms of the reason why they might be having so much sex, whether it could be drugs, or whether it could be mental health, or like some people, I do find they go into a bit of a self-destructive mode, and whether it's using drugs to cope, or whether it's using sexual activity to cope, to try and get some self-esteem. That is something that I see a lot. So, I mean, I know on one side I'm saying sort of normalizing, but I think sometimes there is an element of harm reduction that can be spoken about in there as well.
Absolutely. And knowing that somebody would come and see someone like you, Matt, that's aware of all of that, and clinicians out there that are actually thinking about all of these things while they're talking to you and trying to help you in the best way that they can, whether it is to be proud of your sexual expression, or get extra help or support where you may need it, and have those open conversations. So thank you for that really important stuff. Any other last parting messages about helping people feel prouder to test, guys?
The normalization. Sorry, I think the normalization, is really important. And I think what Matt mentioned is this idea of there is the right way to have sex and the wrong way to have sex that is still pervasive throughout how we discuss sexuality, right? That if you do everything right, if you use the condoms, if your partner looks clean, isn't showing any symptoms or anything like that, you won't get an STI, you're not showing any symptoms. And that, kind of what you mentioned, Erika, where it's did I do so? The idea is you've done something wrong if you have an STI, and therefore that idea you've done something wrong leads to the shame and the stigma, when really it's not like that at all. Sometimes you just get a cold, you don't do anything to get the flu. Sometimes you've not done anything wrong. So it is, and it's the same thing with an STI. Sometimes you can do everything right and it just happens, and most of the time it's not a big deal. And even if it is something more like hepatitis, it's manageable, right? It's there is not it's not the end of the world.
Yeah, amazing. Important messages. Thanks, Drew. And Cara, going to say something, or was it Karen?
Me. I was just going to talk about that obviously rapport can look differently. What I like about the nursing model of care is that we don't just see someone for what they're presenting, and family planning's been good for educating this with workers, but you do a whole history. So you might come in with heavy period bleeding that's problematic, and a part of that is I'm going to offer an opportunistic STI test, even if your risk seems really low, because I need to discount that as part of maybe some future gynae care. So it's about explaining to people why you might ask certain questions and justifying why you need that information, but then also reading the room. So sometimes it doesn't matter how many questions you ask, the patient or client might shut down. And that's okay. That can be for lots of factors. And so then you have to go by that. And I've had someone recently where it got to the point where it was just, so a chlamydia or gonorrhea could be in site A, B, and C. What sites do you think might be your risk factors in order for me to do the right testing? So sometimes it can be just like that. But I like with nursing, it's holistic. It's we're often finding times for testing when someone walks in not thinking that was going to be a part of their journey that day.
again, why we normalise it and why we wish, I think what Karen said, it was around the dinner table or around the breakfast table. What am I doing today? Oh, I'm going to go get my STI test. So it's not such a shock when it does come up in other, everyone thinks it's so separate. And then when you go in for something else and you go, oh, and they give me an STI test, it's actually really a normal and really thorough thing of you to have done. So Karen, you were going to say something.
Oh, thank you. Just two things, if I may. And the first one is that I feel like a lot of our work is around empowering individuals, but I also think that one of our roles is, for many of us in this sector, is challenging a lot of the negativity that still exists amongst some professionals around STIs. I'm still quite horrified when I come across a professional who says, oh yes, I want you to come in and talk about STIs, and show them all the photos of the awful things that might happen to their bits if they get an STI. And it's just such a negative, punishing, shaming approach that sadly still is existing in some people's approach to these topics. So I think a lot of our work is educating them and trying to shift them into a more positive space, that is not the approach. And apart from the fact that it is a very shaming approach, all of the evidence tells us that doesn't work. Can
I just jump in there, Karen? Sorry to interrupt you, but I just want to, because I think that's a really important message that you've just said. And so if there's anybody out there that's watching this and that's happened to you, because sex is something that we still feel shame for as a society, we internalize that, because it's happened to me. You internalize it and go, oh, I'm wrong. So actually, let's flip that message and go, if that's ever happened to anybody out there that's watching this, that's actually not a problem with you or your sexual behaviour. It's actually more of a problem, or says more about the clinician or the person that's treating you that way than it does about
Absolutely.
Absolutely. Sorry, continue, Cara.
So we need to educate those teachers or those workers that are still using that approach, and we need to work with them to shift their approach. But my second point was that I love that the language of be proud to test, and I love the posters that you have, in particular the one that shows young people sitting around talking, having a drink and eating hamburgers, and it's got nothing to do with the clinical setting, and it's bringing in that strength based focus of be proud, and just normalising it, bringing it into conversation. And if those of us in the sector can continue to talk about STIs when we're working in a room with young people around, it's a natural, having sex is a natural part of somebody's life. An STI might happen. It happens to lots of people, lots and lots and lots of people get STIs. They can be treated or managed, and just moving, into a positive place with that, and putting STI testing in a strong place of be proud of taking care of yourself. Look at all these things that you do in your life to take care of yourself. Put STI testing in there as well.
Amazing. Thank you so much, Karen. And any parting words from you, Elena, as well?
I was just going to say, maybe in the future somewhere we might actually stop talking about STIs, and we might just start talking about things like chlamydia or gonorrhea or herpes or human papillomavirus, because in reality, if I've got a wart that's on my finger, is it any different if it's in my genitals? Like, it's still an infection that has happened on my body for whatever reason.
I love that. Wow, powerful. And then that goes into the next hour where we're going to talk about language. No, I'm kidding. No, we are at the hour now, guys, and we haven't had any specific questions come through, which I'm kind of glad about, because we've just gone to the hour, and I thought we might, because you guys have, would have so much to say. So Elena, Drew, Karen, Matt, Cara, thank you so much for giving up your time today to come and talk to us about this. I hope people that are watching have learned something, or have felt more empowered to speak to somebody in their lives, have those conversations. Hopefully we're using this recording to people in the future will be able to watch this and be able to access the services. And at least we know that there are 5 or 6 people in Perth that you can contact via email, by phone. You can find us all on the internet to ask those questions and just get that safe and that humanised and that respectful service. And we can help you to point you to wherever you need to go to the right service for you. So again, thank you so much for joining us, panelists. Remember, STIs happen, everybody. Be proud to test. And we'll sign off now. I've put the feedback form in the chat box there. If you wouldn't mind filling that out for us, that would be great. And otherwise, enjoy the rest of your day. Thank you so much.
Thanks, Erika.
Bye. Bye, everyone.